Today's date is April 13th, 1994. I'm Blake Hailey, and we have with us Mr. Steve Russell, the Executive Director of the Medical Practice Plan here at the University of North Texas Health Science Center at Fort Worth. And we're making this video in the Biomedical Communications Department of the Gibson D. Lewis Health Science Library. Now, after that long spiel, Mr. Russell, I'd like to thank you for taking time out of your schedule to meet with us today. And could I get you to go over a little prior background and what brought you to the Health Science Center?
Sure.
Or TCOM as it was back then.
That's correct. I started out back in the early 70s, 1973, with give you a little bit about my background at the Legislative Budget Board in Austin. And that basically I worked with the House representatives and, of course, the Senate, and working budget preparation for the biennial budget requests that we go through here every couple of years. As well as evaluating those requests. And I stayed there for a term of 4 years, and from there I wanted to get involved in higher education. I went up to Texas Woman's University as the budget director, as well as being over the service departments. Stayed up there a couple of years and had the opportunity to come to a medical school, because that was at least my aspirations, and still is, to work in a medical school. And had the opportunity to come here as the business manager of the institution. So I worked under the fiscal officer. Served under 2 fiscal officers for 5 years, and basically I had the accounting functions and payroll functions and budget functions and purchasing functions reporting to me at that time, and eventually the fiscal plan. So I've kind of gone through the whole gamut on the fiscal side of the house. 1 year I was kind of interim fiscal officer for the institution, and then in August of 1986 I had another opportunity to become the head of our practice plan, which oversees the business functions for our physicians. And I've been there ever since, and it's been a very interesting, and it has been rewarding. It has its up and downs working with the physicians, but I enjoy it, and like I said, I've been in that office and functioning in that office since 1986 to the present time. So that's kind of my background in a nutshell.
Well, this brings up a question then. In becoming a health science center, which has been a lot of our focus in these videos, what were some of the fiscal and administrative concerns and questions that you had to address and think about when becoming a health science center from the College of Osteopathic Medicine?
Well, I think, of course, like I said, my background has been strictly in the fiscal area. I've been involved in other things in the institution. I think the biggest thing important for us becoming a health science center from the fiscal side of it is it gives us an opportunity to be able to as far as cost analysis. Down in Austin, when the legislature is looking at costs, when we were just separated out strictly as a medical institution and just a medical school, when they looked at administrative costs, we were kind of always on the high side, and our cost per students were a little bit on the high side, and we weren't able to disperse our costs like the other health science centers were able to. So I think this gives us a real opportunity to come more in line with what the other medical schools are doing from the fiscal standpoint of it, and be able to get with the state being as tight fiscally as they have been in the past. And from what I hear, this next session is going to be just as tight. In fact, I understand that they're going to ask for us just to come in with a level budget. It allows us to develop programs that we can get funding for to help offset some of the cost administratively as well as financially, to help us I think head down the road and be more competitive.
So our costs are coming down then per student as time goes by.
I think it will, and the reason is because we do have that designation. Plus, it does help us out in other areas also.
Why was it necessary for the growth and success of TCOM to become a health science center, in your opinion?
Well, like I said, I think the biggest thing it allows us. I know that from a practice plan standpoint, it allows us to market our practice plan, because a lot of people look at when you're a health science center, you have more things to offer. So in doing that, I think it allows, from my standpoint, it allows us, we are in the process of right now of trying to develop different programs that we can market our physicians into. And being a health science centers, I think, gives us a little bit more leverage in which to do that. So I think it's been a real plus as far as the physician side of the house is concerned.
What programs would you like to see the physicians get involved in that you're interested in?
Well, as far as from the Health Science Center, of course, the public health thing, which is on the board, and I think probably from a physician standpoint, that's the biggest thing I see out there. I know we have our biomedical graduate program that's in place. That's more, I think, on the basic science side of the house. Although we do have some of our physicians through research and stuff that participate in those programs. But I think that the public health school would be a real plus, and if we could develop like some PA programs, which I know is on the drawing board, there's a lot of opportunities for us to market that out there, especially with the federal prisons, which we are in contractual negotiations with at the present time. So I think those two programs, especially the PA program.
PA stands for?
Physician assistants.
Oh, okay.
Nurse practitioners, those sort of things.
Oh, okay.
Because as healthcare is changing, those are becoming more and more players in the medical care environment.
You think we're on pretty good, the healthcare horizon seems to be changing as far as healthcare reform. Are we in pretty good position to weather those changes, do you think?
I think this institution is way ahead of most institutions in that we're primary care based and have been since inception. And we have an excellent track record in Austin. I think that's the reason that we're in existence, because we've been able to put physicians out in rural communities. We lead, of course, the state in that arena. And where the Clinton plan is going and what you're hearing all around the country is that primary care physicians, PCPs as they call them, are going to be the backbone of this system. Managed care is coming in, which means capitation. So I think we're very well positioned in that that's what we do and that's what we do best. And what these different entities are looking for. If you look at some of the other allopathic schools, they're more specialized in specialties and subspecialties. And in doing that, they're having to make either making a decision to try to stay the way they are or kind of get into the arena of primary care physicians. And we're already there, so we already got the base in place, and I think that's going to give us a leg up on a lot of institutions.
Now, you mentioned that the other osteopathic schools take a different approach than we do with the primary care physicians.
Well, the allopathic.
Allopathic. Now, do you see that being one of the big differences in the state as far as our Health Science Center has to offer that the others are not offering?
Sure, I agree with that. There is one other institution that is beginning to get into that arena, but it's UTMB down in Galveston. But they're more or less going out and buying practices that have family practitioners already established, and the reason they do that is that feeds their hospital system and so forth. Some of the other schools are pretty well staying status quo. Now, one of the things that you've noticed, or at least in my meetings I've had, is that academic institutions are a little slower to change than in the private sector. But I think we're moving. We've added individuals to my staff. So we're trying to position ourselves right at the present to be competitive in that market. And so I think as far as the schools in the state of Texas, that we're well on our way in hopefully achieving where we want to be in the next couple of years, because I think that's when we're going to see the big changes. They're already occurring, but probably the next 2 or 3 years it will really have set in.
You said that there have been academic institutions are slow to change. Why do you think that's the case? Well,
a lot of physicians, when they come to medical school, they don't just come to just practice medicine. They're interested in the academic component, which has got research involved in it, also teaching students. And with the way medicine is changing, the whole crux in the past is the more volume that you could push through your clinics, the more exposure your students would have. Under the new arrangements that are beginning to come about, even though Congress is kind of deadlocked on where managed care is going to go, or where medicine is going to be in the next 10 years. Most institutions, hospitals, and others are beginning to change. I mean, the change is happening without any legislation really being passed. But what capitation means is Blake, is you'll receive so much per member per month. Now, let's say that's on a PCP, a primary care physician, let's say that's $12, $13 per month. You get that irregardless of whether that patient enters your system or does not enter your system.
Oh.
So, you know, it's going to be an interesting teaching phenomenon, I think, for us, because students need to see that volume to learn. But in the same breath, if you don't see any patients, you make just as much money. So the whole buzzword is you try to keep your patients, you like healthy patients, number one.
Right.
And where medical schools on a whole usually get a lot of, because you see a lot of Medicare, you see a lot of Medicaid, you see a lot of indigent care. So we get a lot of cases that we got sicker patients. And a lot of people say, well, that's not necessarily true. But I think overall most medical schools have sicker patients than the private docs on the outside have, because a lot of the private docs still do not accept assignment on Medicaid, Medicare. They won't see those sort of patients. So I think those are some of the reasons.
Whereas an academic institution will see those kind. Yeah.
They will see those kind, and but getting back to that question, in the past there's always been plenty of patient volume. Most medical schools are hooked up to county hospitals or other type of entities, so it's going to be interesting, because the physicians, not only in academic medical institutions but also on the outside, are going to have to change the way in which they practice medicine. And like I said, a lot of them, when they come, physicians come to a medical institution, they're interested in more than just seeing patients. They're interested in research and those sort of endeavors, as well as teaching. So they kind of look at it. They're getting subsidized by usually somebody, in our case, the state. So they're just not as it's a little bit sometimes harder to change those mindsets. And that's across the country. That's just not here. That's everywhere. So we're in the process, or at least part of my role is that we've got to change those mindsets to be competitive, because we're going to have to compete for those patients.
Right.
And the reason we're going to have to compete for those patients, the patient will have a choice under the new healthcare plan, and so they'll be able to go other places. So we've got to position ourselves that the patient satisfaction's got to be very high at the list, so we retain the patient volume we have.
Well, what challenges lie ahead for you? Some of those sound like you've already mentioned. So what other challenges lie ahead for you and MSRDP coming in the future?
Well, like I said, I agree with you. I have mentioned some of those. I think the biggest the challenge that I see is changing the mindsets on how we operate, and that goes all the way from when that patient enters the system till they leave the system, till they pay their final bill. And so we're looking at some things that's a little bit different. We're looking at centralizing more functions, where in the past you had the little individual doc out in their little clinic. They had their own staffs. They managed it from A to Z, and what you're seeing now is these physicians,
like a group?
They're coming into large groups, exactly, Blake. They're coming into larger groups, and when they do that, they're beginning somewhat to be taken out of the managerial role, which kind of goes against their grain somewhat. And so I've got to be able to develop systems, informational systems, that allows them to get the proper information they need to feel comfortable with what we're doing if we're centralized more. So they can spend their time and, again, seeing patients, teaching students, and research and those sort of things. So that's one of our biggest challenges. It's been a challenge all along, but it's becoming more so because we do not position ourselves in the market to be able to compete competitively with these other entities, and then we're not going to have the patient volumes we need to not only teach our students, but be competitive within the arena market.
How else do you see your role changing in the future as executive director?
Well, from what I see, at least from Dr. Cohen's standpoint, he wants me to become more involved in the clinic environment. Right now there's some functions that report to my office, some functions report to the clinics, and at least from the business aspect of it, front desk people is mainly what I'm talking about out in the clinics. Wants me to play probably a more active role in that, and so there's
it'd be
kind of combining all the business office functions into one central area.
Kind of a realignment then.
It is a realignment. It's something that's happening all over the country, and we're looking very hard at that. And like I said, one thing I try very hard to do is that you want to try to get buy-in from those individuals that are out in the clinic as well as the physician, because it makes for a much more smoother transition. And we're in that process, and I think it's coming along.
Probably take another couple of years, it sounds like, to
It
do
probably
everything over.
It probably, hopefully within a couple of years we'll have everything in place, and I think we have to within a year or two, because I think we're going to be, right now the Dallas-Fort Worth area is considered one of the 10 top markets in the country as far as marine and managed care and capitated programs, and from what I understand, that's, we're looking at about a 2-year window, so yes, we do need to have our products in place within a couple of years.
Probably moving faster probably than you'd like it to at some point. So.
I think it is for everybody. And like I said, I feel that we're no further behind, and maybe not any further ahead than some places, but I feel like we're ahead of a lot of entities. I really do.
It sounds like we are ahead of the game. It sounds like to me from what you've mentioned today. We have covered a lot of ground in a short amount of time. Are there some subject areas that you'd like to bring up that perhaps you're going to be involved in or are involved in that we haven't discussed?
I'm not really off the top of my head, Blake. Like I said, I'm pretty well involved in the fiscal side of the house, and I think some of the down in the next session of the legislature, we're going to have to show that we still are unique, and try to come up with some unique proposals that maybe we can get some additional funding while we're trying to get our other components of our Health Science Center going, because it's going to be a very tight budget, and I guess my biggest challenge will be is to try to run our practice plan as efficiently as possible, because we need to collect every dollar possible that we can, because as the state dollars are shrunk, what occurs, and it occurs in all medical schools, they depend more and more on the practice plan to pick up some of those costs to defray. And that's a real challenge with the docs, because things are getting tighter for them also, and the dollars are beginning to be shrunk. So basically what I'll be trying to do during that time is develop those informational systems that allows us to collect every dollar that we possibly can.
So you'll be gearing up here for the legislative session coming up in '95. It sounds like.
Well, somewhat. I don't make that many trips to Austin, but I do get to make probably a couple down there, because they do have some committees that deal with the practice plan, and so we do have some discussions. But I think most of the physicians practice plan feel that the squeeze is coming about. Unfortunately, physicians are going to have to work harder, maybe work longer, to bring in maybe less money than they brought in the past, and I think that's the real thing that physicians have a hard time understanding, which I can relate to very well. You work harder, you usually make more money, but under the new system, it's just that pie is only so big,
right.
And since over 50% of our business is governmental business, Medicare, Medicaid, and CHAMPAs, those are being squeezed down. I hear from Dr. Buchanan in surgery nearly on a weekly basis, and he's become very active. And finding out what's going on, but sometimes on his neurosurgeon he gets 25 cents on the dollar.
Oh.
So it's a real squeeze. So these docs are having to work harder to maintain what they've been accustomed to, and I think they realize that they're not going to be able to maybe maintain some of the levels they've been accustomed to in the past. So. And I think we can we have shown them why that's happening. They understand it. They go to the same seminars, a lot of them that I do, as well as read all the magazines that are out. So it's transitional time.
Well, it sounds like we're definitely in good shape with your help, and you've done an excellent job. It sounds like on your end of it, and I know the school owes you a lot, and it sounds like you're going to continue to serve in that capacity for a while and enjoy doing so.
Yes, sir. I think so.
And we do appreciate.
So.
Well, I can tell, it sounds like you're doing an excellent job. And Mr. Russell, we do appreciate you taking the time out of your extremely busy schedule to meet with us this morning. I know it was probably hard fitting us in, but glad we caught you now instead of saying next year or something. But thanks again. We do appreciate it.
Appreciate it.
And with that, I'll bring to a close this interview. Thank you.
Thank you.